Greetings, fellow humans. Katrina here. Quick disclaimer, I'm a professional, not your professional. Nothing about say should be taken as medical legal advice. This podcast is purely for education and amusement. That is it. Disclaimer over. So I thought I'd talk a bit today about what I don't know about neurocognitive disorders. And I don't know a lot about neurocognitive disorders. It's not a specialty or a focus that I have or an emphasis in my practice. So I will be reading from the Diagnostic and Statistical Manual for or of mental disorders, the fifth edition text revision, which I have been enjoying reading lately. So on page 667 of the DSM-5 TR, we got neurocognitive disorders. NCDs is how I'll be referring to them throughout. So NCDs begin with delirium, followed by the syndromes of major NCD, mild NCD, and their etiological subtypes. The major or mild NCD subtypes are NCD due to Alzheimer's disease, which I'll get a little bit more into 10 tips for visiting a loved one with Alzheimer's in a little bit. Vascular NCD, NCD with Lewy bodies, NCD due to Parkinson's disease, frontotemporal NCD, NCD due to traumatic brain injury, NCD due to HIV infection, substance medication-induced NCD, NCD due to Huntington's disease, due to Crohn's disease, due to another medical condition, due to multiple etiologies, and unspecified NCD. The NCD category encompasses the group of disorders in which the primary clinical deficit is cognitive function and that are acquired rather than developmental. Although cognitive deficits are present in many, if not all, mental disorders, stuff like schizophrenia, bipolar disorders, only disorders whose core features are cognitive are included in the NCD category. The NCDs are those in which impaired cognition has not been present since birth or very early life, and thus represents a decline from previously attained level of functioning. The NCDs are unique among the DSM-5 categories in that these are syndromes for which the underlying pathology and frequently the etiology as well can potentially be determined. The various underlying disease entities have all been the subject of extensive research, clinical experience, and expert consensus on diagnostic criteria. The DSM-5 criteria for these disorders have been developed in close consultation with the experts for each of the disease entities and align as closely as possible with the current consensus criteria for each of them. The potential utility of biomarkers is also discussed in relation to diagnosis. Dementia is subsumed under the newly named entity major neurocognitive disorder, although the term dementia is not precluded from use in the etiological subtypes in which that term is standard. Furthermore, DSM-5 recognizes a less severe level of cognitive impairment, mild neurocognitive disorder, which can also be a focus of care. Diagnostic criteria are provided for both these syndromic entities, followed by diagnostic criteria for different etiological subtypes. Several of the NCDs frequently coexist with one another, and their relationships may be multiply characterized under different chapter subheadings, including differential diagnosis, for example, NCD due to Alzheimer's disease versus vascular NCD, risk and prognostic factors, for example, vascular pathology increasing the clinical expression of Alzheimer's disease, or comorbidity, for example, mixed Alzheimer's disease and vascular pathology. The term dementia is retained in the DSM-5 for continuity and may be used in settings where physicians and patients are accustomed to this term. Although dementia is the customary term for disorders like the degenerative dementias that usually affect older adults, the term neurocognitive disorder is widely used and often preferred for conditions affecting younger individuals, such as impairment secondary to traumatic brain injury or HIV infection. Furthermore, the major NCD definition is somewhat broader than the term dementia, in that a diagnosis of major NCD can be made if there is a significant cognitive decline in only one cognitive domain, whereas a diagnosis of dementia in ICD-10 and ICD-11, and formerly the DSM-4, requires multiple cognitive deficits. Thus, cases that would qualify in the ICD-10 and ICD-11, and formerly the DSM-4, for a diagnosis of amnestic disorder, I'm saying that word wrong, but that's okay. What that is, though, is memory impairment in the absence of other cognitive deficits. And those are diagnosed as major NCD in the DSM-5. So lastly, on neurocognitive domains, the criteria for the various NCDs are based on defined cognitive domains. Table 1, and there's this big table in the book. It says Table 1 provides for each of the key domains a working definitions, examples of symptoms of observations regarding impairments in everyday activities, and examples of assessments. The domains thus defined, although guidelines for clinical thresholds, form the basis on which the NCDs, their levels, and their subtypes may be diagnosed. So now on to 10 tips for visiting a loved one with Alzheimer's. So a lot of people feel pretty anxious about visiting a loved one with Alzheimer's disease, and it can be a difficult experience at times due to both the memory problems and the behavioral problems that often affect Alzheimer's patients. So the following are 10 tips to help you cope and make your visit a little more enjoyable with your loved one. So number 1, position yourself to be at your loved one's level. Number 2, speak in short sentences. Avoid saying remember. So they don't always remember, and that can be frustrating or cause embarrassment. Number 4 is only ask one question at a time. Number 5, speak slowly. Don't talk down to them. There's a fine line there. Number 6, do something when you visit. An activity, it can be music, a special meal, stuff like that. 7, don't get frustrated when they keep repeating the same story or asking the same question. 8, if your loved one gets agitated, change the subject or stop what you're doing. 9, do not correct your loved one if they are mistaken about something. And 10, keep visiting even if your loved one doesn't know who you are or doesn't seem to know who you are. So this is straight out of the reliantmedicalgroup.org blog from 2021. If you're interested in looking that up, I'll put a link in the references section. So I do hope you enjoyed today's episode. If you'd like to contribute to the show, click the button on the website, and I do appreciate each and every one of you simply for existing.